This is One on One. We're honored to have Dr. Anthony Costa, who is an orthopedic surgeon, Meridian Orthopedics, and also medical director, Total Joint Center at Riverview Medical Center. Good to see you, doctor.
Thank you for having me, Steve.
Let's talk a little bit about osteoarthritis. What is it?
Osteoarthritis. The, quote, regular arthritis, if people talk about having arthritis, this is the one that they're talking about typically. There's over 180 subtypes of different arthritis.
No.
Yeah, there's a lot. But the most prominent is osteoarthritis. That's the one that affects most
Genetic?
people. There is a genetic predisposition. We haven't figured that out as well yet, but we know that it's a multifactorial problem. But yes, you can blame mom and dad a little bit because there is a genetic.
I could blame my parents for that too?
Please do.
Good, I got a long list here. No, I'm like kidding. Let's do this because there's rheumatoid arthritis.
Rheumatoid arthritis.
What's the difference?
Rheumatoid arthritis is a systemic problem, meaning that it's there's an autoimmune factor to it where your body is attacking its own joint. Whereas the osteoarthritis there is a wear and tear portion where your weight and your activity affect the osteoarthritis significantly. Not where you would have your body attacking itself, but rather the external forces, environmental forces weigh in hard.
Let's talk about some of the options because there are apparently all the information is that there are more options today than ever before if you have osteoarthritis. Let's talk about them. What are some of the options?
The beginning, I mean, I'm an orthopedic surgeon, and yes, ultimately you will get to the point where you may need to have the joint replaced.
But you do try to avoid that.
Yes. Yeah.
How?
Multiple ways. Once we figure out through the x-rays and your physical examination and your history, where do you lie on the spectrum? Do you have mild arthritis? Do you have moderate arthritis? Or are you way over here in the severe arthritic range? If you're in the mild or moderate, there are many non-operative treatments. Diet and exercise always, losing weight.
What does that have to do with it?
Because if you're doing, studies show that low impact aerobic activity is actually better for patients with arthritis. Now you would think that, well, it's wear and tear, but how would exercising it be good for it? And it turns out that my most happy patients are the patients that get up and exercise on a near daily basis.
So let's clarify this. We use terms, low impact, not low assume. I do stair stepper, elliptical. My wife is constantly on the treadmill, and I avoid the treadmill. She is younger. Part of my logic is that the pounding on the treadmill bothers my knees. Am I wrong?
No, you're not. I mean, in the exercise that you named, that elliptical machine and is going to be less impact than walking on a treadmill. But the treadmill, what you were saying is exactly right. Try it. See how it makes you feel. The higher impact exercises are more like jogging.
Especially out in the street.
Right. Basketball, those type of jumping type of things.
Okay, let's talk hip replacement, knee replacement, improvements. What are they? And by the way, let's give guys, can we get a shot of this? Steve, you have a shot? Steve Barcy? Talk about, what are we looking at here?
Well, this is a knee prior to a healthy knee.
This is a healthy knee.
This is a healthy knee. So we have thigh bone, leg bone, and then the kneecap.
Got it.
When patients think of arthritis, a lot of times they think that I have a problem with my bone, and that really isn't the primary problem. The problem is the cap of the bone, which is called the cartilage. The cartilage wears away. That's what causes an irregular surface here, and then eventually you get bone on bone. Exactly right. When you go through all the conservative measures, you're not able to get relief and you're functionally limited, you can't pick up your grandkids, you can't do the things that you wish to do, eventually you get to the point where that cartilage cap has worn away so badly that injections aren't helping, Advil's not helping, none of these things are helping, you need a knee replacement. People think that it's replacing the entire knee when really I just need to replace that cartilage surface.
Is that when you're moving here?
Yes.
Let's move over here, guys. Take a shot.
So instead, knee replacement meaning cut here, remove and replace. It's more of a resurfacing. So if I turn this to the side, you'll notice there's a thin coating. That's all that is removed during the knee replacement in order to get, let's see if we can pull that off here.
Oh, so that's interesting. You're not replacing as much as you previously did.
Correct. Well, the replacement amounts are about the same. However, we're not removing big parts of bone here. We're just taking, it's more like capping a tooth. If you have a cavity, you take out the cavity, you leave as much tooth as you can. Same concept here. We're removing just the end, the cap goes on the bottom part, the cap goes on, and plastic goes in between.
What's the advantage here?
That plastic used to last about 10, maybe 15 years. So people think, I don't want to have a knee replacement. I'm going to outlive this thing. I'm going to have to go back into the operating room in 10, 15 years. That's really not the case anymore. Since 1997, the plastics increase in the quality significantly. So now we're thinking more like 20, 25, possibly 30 years.
Use it longer. Real quick, before I let you out, Jen, help me on this. The hip, the anterior approach to the hip.
Oh,
real quick on that.
Anterior approach, there's many ways to access the hip. You can have an incision by your butt, kind of way in the back there. You can have it on the side and in the front. Through experience, I mean, we've generally speaking, the conventional way to do it is through the back. I now come in through the front. This is not a new thing. It's something that I embrace because I think that the patients get up faster. Why? The incision's around the 3-inch mark. I'm cutting less to access that joint space. By cutting less and having the soft tissues managed better, the patients are getting up a little bit faster.
Recovery faster?
Yes, sir. The data is the first few weeks, we think that there's evidence to say, yes, people are getting up and moving faster. After that 6-week mark, really everything kind of melds together and everybody does well ultimately. But it's my goal to get patients up immediately after surgery, and that's what they do. We have the surgeries on Friday, you're up walking on Friday.
What?
Yeah, same day surgery.
Amazing changes.
It's happening.
Dr. Anthony Costa, involved in some really important work that is impacting a lot of people, orthopedic surgeon, Meridian Orthopedics, medical director, Total Joint Center at Riverview Medical Center. I want to thank you for talking to us. A whole lot of people out there dealing with hip and knee and other orthopedic issues. We appreciate it. Good stuff.
My pleasure, Steve. Thank you.
One-on-One with Steve Adubato has been a production of the Caucus Educational Corporation, celebrating over 25 years of broadcast excellence. Funding for this edition of One-on-One with Steve Adubato has been provided by Delta Dental of New Jersey, the New Jersey Education Association, Wells Fargo, New Jersey Sharing Network, the law firm of Gibbons PC, Verizon, and by NJ Best. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area.